Right now?
Yeah, fix it right now.
Man, that's asking a lot.
Like
So,
if I sit for too long, it gets stiff.
yeah. Have you tried to do any like soft tissue release stuff to it, like a golf ball or anything like that? You can do some of that. That'll help.
I mean, I could tell you yes, but
Yeah,
come on.
yeah.
No,
Let me needle it.
right now. You want me to
If I
just
had
drop
some-
my
if I had
trowel?
some needles, man.
You want me to show you my?
You
You want me to show you my Superman underoos right now?
now?
Yeah, fine. I'll come and see you.
Yeah, come on in.
Come over. Yeah, or come
Shoot
by
me- shoot me-
UH.
Shoot me a text, or yeah, I can do that. Shoot
Come
me a
by
text or
UH.
something.
Just so that's what it is. It's my QF.
QF.
So I don't have an osteogenic sarcoma or anything like that.
I don't believe so.
Yeah, okay.
I mean, I can't say that for sure, but
Yeah.
you can't put me on the spot like
What?
It's,
Yeah.
it's going.
Okay. Oh, we're live.
Yeah.
We're live. Hey, everybody. What's up? This is Dr. Josh Yellen on the Sports Medicine Broadcast. I just had Chris Juneau give me a comprehensive hip evaluation, and thank God for Chris, because he assured me that it is my QF in my hip that's causing all that pain.
That's
And
right.
so if my wife is listening, I sent them a link to the broadcast. If my mom and dad are listening, everybody just calm down, okay? This is just a muscle issue.
That's right.
All right.
Bill's in the mail.
Yeah,
so,
thank you.
okay.
I wouldn't
Just wanna
expect
make sure
anything
we're-
otherwise. Right, I wouldn't expect it. All right. So Chris's presentation today was about hip preservation program, and he's got a wealth of information about this. But before we get into that, I want to talk to Chris about his bow tie.
Ah, yeah.
I mean,
Yeah.
anybody with a beard, right? And he's got his bow tie. And so, did you tie this tie yourself?
Oh, absolutely. I
okay.
can
So,
retie it right
like,
now.
are you like? Can you do it without even looking?
Oh, sure.
So, are you a bow tie connoisseur?
I wouldn't call myself a connoisseur.
How
No,
many
I
bow
have some-
ties do you have?
Ooh, 75 maybe.
Are you serious?
Oh yeah.
That's a
Well,
connoisseur.
here's,
I have one.
But here's the thing, though, right?
I have
is,
one.
Is as soon as somebody knows you have a bow tie, right? What do you get for Christmas? What do you
A
get
bow
for,
tie.
Yeah, right. Every
Uh-huh.
patient's like, oh,
So you get a bow tie.
I get a bow tie.
So, like, do you wear bow ties at work, or you wear like a
you
polo,
know,
or
I wear a polo. However,
Uh-huh.
every now and then I'll
just rock the bow tie?
I spice it up for Friday. Rock a bow
Right
tie
on.
for a day.
Right
know?
on.
I mean, it's hard
Well
to
done,
beat.
sir.
Yeah.
I mean, I just got to throw it out there. Well done. Well
I
done.
feel good about it.
Yeah, you should feel
Power
good
tie.
about it. It is. It is. All right, back to what we're here talking about. So tell us about, for those that weren't able to watch the broadcast live
Sure.
while you were presenting a phenomenal presentation, tell us about hip preservation, right? Because one, if I use my dad as a case study, my dad was a big power lifter,
Okay.
weightlifter. If I use me as a case study, if I use my son as a kid, we all seem to have hip issues.
Sure.
Right. And so the more active that the population gets, the more hip issues we're going to see. And it seems like these hip replacement operations are happening younger and younger. So
Yes.
how do we talk about,
Yeah.
so tell us about what your preservation program is all
Right.
about.
Well, so I guess it's easiest to start with what are we preserving, and ultimately we're preserving the hip, but we're preventing or mitigating the onset of arthritis, right? The problem with arthritis, and probably with any cartilage defects in the entire body, is as soon as you go down that path, there's really only one or two options, and that's some type of resurfacing procedure or a total joint replacement.
Mhm.
You know, and there's nothing wrong with those procedures. They just don't have the sealing that normal anatomy does.
Mhm.
And so we're attempting to prevent the breakdown over time of these conditions. And so the preservation program identifies patients or clients, personnel that are at risk for developing lingual tears or fancy word intra-articular, which is inside the joint type pain.
So go back to at risk. How do we identify at risk? Give us some qualifying factors that you use in your program.
Right. So the three that I spoke about in the presentation, it was a bit of a Venn diagram. But one is strength and really motor control. Right.
Mhm.
So if you move poorly,
Mhm.
you're at risk, and you're not just at risk for hip pain. You're at risk for a myriad of other type
Mhm.
conditions, knee pain, et cetera, back pain, et cetera.
Mhm.
So strength is one, specifically glute strength
Okay.
and local hip control.
So when you talk about glute, right? Everybody knows there are three gluteal muscles. So we're looking at gluteus maximus, gluteus medius. We don't really use a minimus because we're not squirrels.
That's correct.
Right.
That's
Thanks.
correct.
Yeah.
It's
okay.
it's in there, right?
Yeah,
Right.
it's there, but we don't really
the
know.
other ones that we don't talk about are the rotator cuff muscles of the hip, and that's
Okay.
your QF, as
Yep.
you obviously know now.
Pain,
right?
right?
Your piriformis,
Yep.
the obturator group,
Mhm.
and the gemelli
Mhm.
population. So you have 6 muscles that really function to compress the femur into the acetabulum, very similar to what your rotator cuff functions to do, and provide a little bit of compressive force. And so we just don't train those, very similar to the way that we don't train our rotator cuff until something goes haywire.
Did you ever learn about the theory of ontogeny, recapitulating phylogeny?
Oh,
yeah.
sounds fancy.
It does. It's big words. That's what a doctoral degree gets you. So, and a lot of student debt.
Yeah, sure.
And so that theory says that and again, it's just a theory. At some point, we were quadrupedal mammals.
Sure.
Right. And if you look at the human body, it makes sense as quadrupedal mammals, right? Because the femur looks a lot like the humerus, and the tibia and the fibula look a lot like the radius and the ulna, and obviously the carpals and the tarsals and all those other things. And so everything makes sense as a quadrupedal mammal, but as we start to erect, okay, and we look at where the spine is in relation to where we really need it to be, right? It's still posterior, and you have all these forces anterior, and you have all these other things happening. Well, you mentioned the rotators or the rotator cuff of the hip, right? The Gemelli brothers, right? I kind of think they're part of the mafia. The piriformis, the QF, all those other things, and it looks a lot like the rotator cuff muscles of
Identical.
right, almost identical. And so people don't look at it that way.
Of course not.
And the hip is just one of those joints that like people don't understand.
Right. Which is why I think we've gotten into this point. I mean, the thing when I'm lecturing is take the shoulder. Let's take the hip. Right. The shoulder. If you came in with shoulder impingement, most practitioners would agree. Right. You look at posture. So you fix somebody's lumbar spine. You fix their T-spine. Right. You look at their hip, as in the acetabular side. You also fix their scapula, right? You're looking scapular, and then you're looking at rotator cuff, i.e. the rotator cuff of the hip. And so it's very similar. We just, for whatever reason, haven't equated those things yet because this hip phenomenon is a bit new.
Right. We can't make these one-to-one, relations that, okay, the shoulder, which is kind of what I call a pseudo ball and socket joint,
right?
It moves very similar to the hip. And it's just, all right, so let's go back. So one is you talked about the
strength.
Yeah, the strength. Right. So what's a qualifying factor? So strength, motor control?
Yes. Both of those would be the case, right? Being able to do an isolated glute set, having enough range of motion to go into like a single leg bridge, getting to neutral. Most of us are tight enough anterior that if you put somebody in a single leg bridge, especially an elevated foot bridge, you're not even close to 0 degrees of knee to hip.
And what are so important about these facts? I mean, just for people that aren't listening.
Sure.
Right. I had the privilege of listening to you and learning a tremendous amount. And so for those that didn't get to listen to your lecture before, tell us about why are those types of assessments so important and what exactly are you looking for?
Well, compression into the hip joint is one, very similar to what the humerus would be to the glenoid and the scapula. And ultimately this happens, and it's the easiest to comprehend in the knee. If you lack knee extension, and I mean full terminal knee extension, your quad muscle will never be as strong as it would be. It's just, it's necessary. And so if your hip cannot get into extension, and not lumbar extension, I mean hip extension, FA extension, your glute is not going to be. It's
never gonna fire the way it's supposed to.
I mean, for those of you at home, get in a half kneeling position. Try to squeeze the glute on the leg that's in front of you. Good luck.
Yeah, right.
Good luck.
So when I'm out there gardening like I was Saturday, and I'm going to pick some weeds up, and I go to kind of bend over or squat down, and my hips start to shake a little bit, those are my glute medians. They just aren't firing. They're toast.
Right. And it's not strengthening. And I want to make sure that that's the biggest factor. Is it's not necessarily strength, it's motor control, right? It's neuromuscular efficiency. There's a big difference between having big glutes and being able to use them. It's nice to look at, right? But
yeah, it depends on who you are. Yeah, sure.
You can't use them. What are we talking about?
What does it matter? All right, so tell me more about those qualifying factors. Okay. So you're looking at
strength and
motor control. We talked about those assessments that you just talked about.
Right. Okay. And movement is ultimately a risk factor, right? Very similar, again, if we get into shoulder mechanics. If you're an overhead athlete, a thrower, like a javelin thrower, baseball, football, being in that position is just not good over time for your shoulder.
Sure.
And so it's not necessarily that you have bad morphology or you're weak per se. You picked a sport or you picked an activity that you're over your head. You're a construction worker that's carrying things. It's just tough on your body.
Your body's not meant to do that.
Right.
In today's world, we do a lot of that.
Right. And in the hip, specific activities, crossing your legs, being squatted for long periods of time, or the easiest is a goalie. Right? If you're a hockey goalie and you move into like a butterfly position to block the puck,
Sure.
you're in internal rotation
All the time.
all the time.
Right.
And that's just, again, most of us do not have.
Body's not supposed to do that.
Not
So what about like a baseball catcher?
Same thing.
Okay,
Same
so
thing,
he's
right?
constantly in that externally rotated position all the time.
Right.
Squatted
Until
down.
they go down a block, and
Right.
you want to cover the 5
Right.
hole.
It kind of,
right?
but yeah,
yeah.
butterflies down.
Mhm.
So now we're all right. So now we're looking at the offensive lineman, the defensive
All of them.
lineman. The,
Exactly
all
right.
right. So now let's take those movements and put them into non-athlete populations,
Sure.
construction workers,
Gardening,
gardening,
right? Bending over,
teachers,
all of this, where you're sitting for long periods
mail
of time.
carriers.
All the time.
Okay.
Yep.
Yeah.
And then to compound all of this, you have this third little caveat or risk factor called dysplasia or morphology.
Mm-hmm.
And this gets into what people typically talk about when they talk about FAI.
Mm-hmm.
This is your camera.
And for those
picture.
that, right, so for those that have heard FAI,
Mhm.
explain FAI stands for,
Femoral acetabular impingement.
and talk about the overall concept
Right.
of that.
So femoral acetabular impingement is the same theoretic construct as impingement in the shoulder. It's
Okay.
the abutment of two structures.
Mhm.
Now this can happen anywhere in the body. If you take your elbow and you extend it all the way straight,
Mhm.
you're having technically abutment or impingement of the olecranon.
Mhm.
Right? It runs out of space. Bones only go so far. The joints are designed that way. And so what FAI is defining is an abnormal abutment and or a premature compression of these structures of the hip, specifically the femur and the acetabulum. So
Okay.
ball meets socket way too early and
Right.
causes compression of the labrum of the cartilage, which generates pain, which you go see your doctor and so on and so forth.
Okay, let's go back to what you were talking about.
So if you're thinking about, let's say that you decide you're going to play goalie, but you happen to have these morphologic characteristics, i.e., you have a cam or a pincer, which are an abnormal shaping of the bone that predispose you to compression or abutment earlier.
Mm-hmm.
So now you got bad anatomy. You chose a sport that's not great for your hip,
And you got bad mechanics.
and you're weak. Oh,
Right.
God forbid. It's the trifecta.
Yeah, right. This is a perfect storm.
The perfect storm, and then your hip is a disaster.
Yeah.
You're 18 years old and it hurts to walk.
Right.
It hurts to sit, and you're like,
Right.
is this really it for me? And naturally, there was a time point where somebody down the road, 20 years ago, had said, "Well, I don't really know.
Mhm.
You just need to stop doing those things.
Mhm.
Sports are not in your cards." And guess what? They get better because they don't put their hip in positions that make it worse until down the road where they're probably weak enough and it degenerates enough where they end up in the total joint camp.
Mm-hmm.
Unfortunately,
And it's happening. Yeah. So that's probably one of the reasons why we're seeing the baby boomers
that's right.
having joint replacement surgeries early and earlier, is
Correct.
because they didn't have this information when
Sure.
they were in their 20s and then their teens, and just over time, this has just created this
Right.
kind of destruction.
Right. And strength and conditioning wasn't that wasn't exactly a priority for most of our baby boomers growing up.
Yeah, my dad, he tells me stories. He sent all the strength records at Cal State Northridge when he was
Sure.
there, and his first squat cage was a couple 2x4s. This is your speaking gift, York
Yes.
peppermint patty, is it?
I'm pretty damn clever. Look at this.
I'm sweet.
Yeah. What?
My commitment.
And involvement.
That's pretty good. That's pretty good. Ladies and gentlemen, Bob Marley.
Mama.
Yeah. All right. So let's go back. So we talked about the criteria for inclusion. We talked about motor control. We talked about muscular development. We talked about morphological issues that you can't really control.
Right.
So now let's get into the meat of the preservation.
Yeah, so it's management, right? The obvious is like, well, Chris, that's great information. I appreciate you enlightening me, but I need to know how to fix this stuff. And this is where it gets messy, right? Because one of the lead-ins to my presentation was FAI is a spectrum and a syndrome, and it's not a diagnosis. So I don't care if somebody says, "Hey, Chris, I have FAI." That's nice, but that doesn't help me very
Right.
much at all because of the factors we discussed earlier. So what we typically see is an evaluation process that attempts to deload the labrum or the cartilage, which are the painful generating structures.
Mhm.
So you don't have pain with FAI. You have pain because you have a labral tear or cartilage
Right.
damage.
Right.
FAI is the risk. So we try to eliminate the risk.
Mhm.
So if you came in and you said, yeah, I'm having hip pain, it's worse with sitting, it's worse with, okay, so let's look at your strength, let's look at your movement, let's look at things that I can manage. If you have these morphologies, I can't change that.
Right.
Not
This
without a hammer and a
this
chisel.
is the way you came out of the factory.
Right.
I can't do anything about that.
So we try to eliminate and really decipher what is driving your symptom. So if you've had these pieces for 30 years and now all of a sudden you have hip pain, why now?
Right.
Maybe it's not the bones. Maybe you decided to, oh, you know what, Chris, I decided to start doing some increased boot camps and it was a lot of bottom squatting.
Yeah, right.
Maybe that's why your hip is where it is.
Increasing mileage, just walking around.
Mileage, right?
Right.
Maybe
the 10,000 steps a day. I'm just
right.
working these different hills.
And the worst thing, right, is if you think about the knee, right? If you have an effusion in your knee, what shuts down? Your quad. And that actually makes your knee worse. It's protective initially, but you have to get it back for protection. So if your hip is effused, which you can't see,
right,
your glute shuts down. And if your glute shuts down, guess what happens? It perpetuates the process.
Right.
And so sometimes it's as simple as quad sets of the hip, doing some glute retraining, doing some movement retraining.
So let's talk about that, right? So you go back to for those that don't necessarily understand the rehabilitative process the way that you understand it, everybody is familiar with, quad sets. Right. So start to tell them what's in your protocol for glute sets.
Yeah, so we start prone glute sets and we do it with a combined core contraction. Okay. So how I do this, and for everybody listening, imagine if you're lying on your stomach and I put a towel underneath your pelvis, right over basically your belly button to your pubic symphysis. Okay. And I'm going to pull that towel out and I say, hey, don't let me pull this out. You're instinctively going to, it's basically a core contraction, right? And then I say, all right, don't let me pull this towel out and do a straight leg raise, or actually just start with the glute set. Can you squeeze your glute muscles? Be amazed at the amount of people that have no idea. It's a brain connection malfunction, right? They have no idea. Their hamstrings are on, their back's on, they're kicking their leg out, their quad activates. They have no idea how to intimately contract a glute. Just don't know how. And so we do a lot of retraining. We use biofeedback, which is excellent stuff if you have access to some surface EMG biofeedback. And then if you want, this is kind of a different way to approach it. If you put them in a little bit of hip flexion and have them extend to neutral, sometimes it's easier to find a muscle when you let it move a little bit.
In its physiological range of motion.
In its physiological range of motion, exactly right. Instead of just putting it in range, maybe you put it at mid-range and let it recover to in-range. Almost like a leg extension, right? It's hard sometimes to have somebody do a quad set all the way straight. Sometimes it's a little easier to have them do maybe a short arc quad, maybe to the last 15 degrees, because you can visually see and proprioceptively see that.
I think for all the young people that are listening, I think that if you're going to be successful in this area, you need to know anatomy, you need to know physiology, you need to know biomechanics, you need to know motor learning. If you know those four things and have a core understanding in a solid exercise science undergraduate curriculum, something along those lines, the things that Chris is talking about aren't going to be foreign concepts to you. Right. You'll have a solid understanding of what's occurring.
It's easy to do the fun stuff. Right?
Yeah, right.
I mean, PTs are notorious. We want to be liked. We are people pleasers.
Yeah.
And what's not real pleasing is to sit on a table for 45 minutes and do glute sets and single leg bridges.
Right.
However, if you want my personal and expert opinion, then that's where we see the biggest dividends.
Right.
It's just not fun.
And so now fast forward us through the hip preservation program. So now we're on to the glute sets. We're on to identifying. And as you're talking, I'm thinking to myself, okay, I got to start doing this stuff now. And so get us through, start progressing to functionality of where you want us to be.
So what I love is split squats, where it's a reverse lunge, right? Where you're putting some basically some elongation of the contralateral hip flexor and loading the glute of the decelerating leg.
Okay.
Love that.
And why do you like that so much?
Because of the exact thing, getting into hip extension. We just do not do enough to get into pure hip extension. just our typical day-to-day life is too much flexion based.
Mhm.
We just don't do
A lot
enough
of
those.
sitting, a lot of
Lots
driving.
right? And then squatting and all that. It's just not terminal extension.
Mhm.
So bridges, elevated bridges.
Mhm.
Oh, it's my jam.
Yeah, that's it.
Oh, it's my jam. Yeah,
Okay.
put your foot on a box, on a 6-inch box,
Mhm.
pull your opposite leg to your chest, granted it doesn't hurt,
Mhm.
and try to extend your hip to neutral.
Can't do it.
Not even close. Most people couldn't even get close.
Mhm.
And then again, some of the lunges as well. And then we start moving into kind of some extension patterning, right? So this will be hard to maybe conceptualize, but imagine standing in front of a functional training device, right? As in something with a pulley, like a cable system.
Sure.
Turn around the opposite way and pull the band between your legs,
Mhm.
almost like you're doing like a kettlebell extension,
Yep.
right? I start with that, and then we get into kettlebell extensions.
Mhm.
That facilitated slamming, what I call slamming the door,
Uh-huh.
right? Really squeezing your butt, straightening up as
Uh-huh.
you squeeze. And that, again, starts retraining like, oh, wow. Like, I can feel my blood working.
Right.
I don't know when was the last time I had my glutes this sore.
Just fire like that. Yeah, right.
And then ultimately getting into progressing depth if that's indicated.
Okay.
Right. If you're a catcher, then we start doing maybe some pause squats,
Mhm.
some holds in the bottom, where in your squat position, we're working on core contraction.
So if I were to piece together the last two talks, right? Ryan talked a little bit about,
Mhm.
hip issues and looking at training as far as rehabilitation. You're really talking about the hip preservation. So if I really start to scaffold all this information, where you are is we're back into let's prevent this from happening,
Sure.
and we're going to move forward to what Ryan just talked about.
Right.
And now we're going to start to get into the functionality of what's occurring and how it's occurring. And so for those people that are listening, let's just say I've got Joe Blow that just happened to tune into this, and Joe Blow is wondering how do we get these athletes to move more efficiently? How do we tell us some things that give us 2 or 3 things that you would recommend to the average person that doesn't understand this the way that you understand it.
So one of the biggest things is we as a society have moved away from isolated muscle strengthening, and not because it's, again, I don't think it's a bad thing, but boot camps and classes are really popular because it's HIIT training, right?
Right.
I want a lot for a little amount of time.
Right. And it can be done anywhere.
It can be done anywhere, right?
Right.
The problem, though, is that assumes that you are muscularly compliant and competent. And so what I would challenge most people is to do both.
Yep.
To do both.
Okay.
And that means doing functional training, squatting, stepping up, things of that nature. Great. But also spend some time in the gym, do your bridges, do some of these lower leg things where you're isolating muscle groups. That can go a long way, a really long way. And then your core. Everything should be done with good core control. And if you are in bad position, everything's in bad position.
All right. So you're getting paged out because you have a thing. So if somebody wants to get in touch with you, how do they get in touch with you?
You can certainly email me.
Yep.
That's probably the easiest way to do that. And that is Christopher.juneau@memorialhermann.org.
Okay.
So that is CHRISTOPHER .Juneau. It's JUNEAU at memorialhermann.org.
Chris, I appreciate your time.
Absolutely.
Go and educate.
We'll do what we can.
Yeah. I'm going to come find you and see if you can poke around my head for a little
Sure,
bit.
man.
All right. Thanks.
Pleasure. Yeah.
All right. Bye.
Cool, man. Thanks for having me.
Hey, thanks a lot. Thanks for being here.
Absolutely.
So I think we're going to transition here to a little bit, right? I think Jeremy Jackson's got some plans of maybe putting some people on while they're teaching. And so we're going to take a look.